Ultrasound is a widely used imaging technique that provides real-time visualization. Its popularity in the ICU for critical care diagnosis and management is increasing. This presentation aims to give you a basic understanding of how it works and equip you with the skills to effectively use the machine. The objectives of the presentation are pretty straightforward. Review the basics, physics of ultrasound, review ultrasound probe selection in critical care, review basic ultrasound machine navigation and adjustments. It's important to say this presentation it's meant to give you an initial understanding of the machine. It's not an all-inclusive or comprehensive ultrasound physics lecture. I include this slide mainly to highlight all the different types of artifact that we have in ultrasound. So again, this lecture is the basics. It'll get you started, but this is not an all-inclusive. The first thing to talk about when we have an ultrasound machine is understand what it's doing. So this machine sends out sound waves, and those sound waves hit some tissue or they don't hit some tissue, they reflect back. The machine interprets these sound waves and puts out an image. So the first thing to know is kind of get a feel for how sound waves travel. So there's lower frequency sound waves and there's higher frequency sound waves. So lower frequency, so that's AM radio or deep bass sounds, those are lower frequencies. So you can hear them from a far distance, but they don't always sound so clear. On the other side of the spectrum, you have higher frequency sound waves, and I like to tell people, think of FM radio. So FM radio sounds good, it's clearer, but you can't hear it from the distances that you would, say, an AM radio station. So these probes are either at the lower end of a frequency or a higher frequency. So the lower frequency probes will go deeper into the body. The higher frequency probes will give you a better image. So knowing that lower frequency probes give you more penetration and higher frequency probes give you clearer images, these convex and phased array probes are the general probes you're going to see on the machines in the ICU. And then you're also going to see a linear probe. The phased array and the convex probe, they operate at lower frequencies, the linear at a higher frequency. What you need to know is basically that. I mean, there are numbers for these frequencies and there's a range of that each probe can do. But the most important thing to know is just what probe to choose and kind of how they work. The other thing that's important to highlight is kind of how the sound waves come out of the probe. So in the curvilinear linear, sound waves come out this way, they reflect tissue and come back, and then you get an image on the screen. On the linear, they just go straight down. So that's why you choose this probe when you're putting in a line or for vascular access. This probe, the phased array probe, what's nice about it is it has what we call a small footprint. So this probe is often used to obtain cardiac images, and the reason you use it is you want to work between ribs so you can see the hearts. So picking the phased array gets the sound waves between the ribs, and you can see what you want to look at. If you were to grab the curvilinear, you would have several ribs in your way and the image would be obstructed. So these are the probes you're going to use. The phased array when you're looking at the heart, and actually the phased array can look into the abdomen as well. The linear, maybe when you're putting in a line, can look at the lung with this, but that's really what you're going to use those for. So to summarize, and again, everybody's preference is different. My preference is if I were to just use two probes, it would be the linear and phased array. The linear probe operates at a higher frequency, the phased array a lower. The wavelength is less important, but shorter wavelength with the linear, a longer wavelength with the phased array. The linear probe will have less penetration. The phased array and the convex will have greater penetration into the body. Your resolution on the linear probe will be much better compared to the phased array and the convex. In general, linear probe is used for vascular access and lung sliding. Phased array for the heart for sure. Phased array can also be used for the abdomen. The convex probe should only really be used for the abdomen or potentially the subxiphoid view because the ribs aren't in the way. So when you are obtaining an image, you need to know how to communicate your findings intelligently to your colleagues. So a couple terms that you should be familiar with. The first is hyperechoic. So remember hypertension, so high. With a hyperechoic finding, so this white is hyperechoic to this tissue here. And all that means is because this is a dense object, a lot of the sound waves are coming back, and that translates to a white image on the screen. So this is hyperechoic to this. Hypoechoic, so we'll talk about this later in other lectures, but sound waves, when they go through less dense tissue or fluid, they are not reflected by anything, and that image appears either dark or black on the screen. So this little gray area is hypoechoic to this area. ISO, so the same, isoelectric, the same, no movement. We don't see the circle here because it's isoechoic to this. I would say this term is used less frequently. And then anechoic, so ana, without. This area here, there's no echoes coming back to the probe. They all go through the fluid. They don't come back until later. So this is anechoic to this area. So kind of building off the last slide, echogenicity, that just means the ability to reflect an echo. So all the structures in our body have some sort of echogenicity. Fluid, there's no ability to reflect an echo. So those are anechoic. And they are, what you're going to see on the screen is black. So things that are anechoic or sometimes called hypoechoic are urine in the bladder would be one. Ascites, anything that's fluid, pleural effusion, hemoperitoneum, so blood in the abdominal cavity, all those things are going to be black on the screen, called anechoic. Hyperechoic, so those are things that reflect a lot of echoes, so dense structures in the body, things like bone, ligaments, dura, nerves, the pericardial sac, the parietal and visceral pleura, those structures will be white or hyperechoic. And then tissue, muscles, those will be some sort of iso or hypoechoic finding or gray on the actual screen. And then I do want to point out here, this all looks kind of white, right? So you think to yourself, well, what is that? Well, it's not a dense structure, and this is kind of, I'm highlighting in this lecture, basics, but this is what's called acoustic enhancement. And what's happening here are the sound waves are traveling, nothing's reflecting here, so a lot of them are kind of hitting this area, and you're seeing on the screen what maybe looks like a dense material, but this is an artifact. So I just highlight that so you kind of understand that we are just talking basics here. So you always need to understand, at least when you're starting to scan somebody, the orientation and which way. There's a little indicator on all of these probes that the indicator will coincide to this little dot here. So you always want to know where your indicator is when you start scanning a patient. And each transducer will have an indicator on one side, and again, that corresponds, this little indicator will correspond to this image on the screen. Another thing I want to point out as far as orientation, for the most part, most ultrasonographers, the indicator will be either to the patient's right, pointing, or pointing towards the head. And you're going to see the orientation mark on the left hand of the screen, so it'll be up here. Now, cardiologists do it a little different, and formal echoes do it a little different. And you're going to see, I don't want to confuse anybody because we're going to start just doing general. However, there are some advantages to choosing cardiac mode. When you put the machine in cardiac mode, a little indicator will go to the right side of the screen. And to scan those patients, generally, the indicator's towards the patient's left, and the orientation mark is on the right side of the screen. That will make more sense when we go over that, but I do want to highlight that cardiology mode and general mode, general ultrasonography, are different. Here's a nice example of how, so this image is, these are subxiphoid views of the heart. So this is abdominal mode, this is cardiac mode. The images look the same, right? So you have the RV here, the RA here, the RV here, the RA here. They look the same on the screen, but the indicator is different. So with that said, when you start the scan, you're going to choose your exam. When you put it in abdominal mode, that little indicator is going to be on the left side of the screen. You put it in cardiac mode, the indicator would be over here. In vascular mode, again, the indicator would be on the left side of the screen. And then I'm going to show you 2D or M mode. And 2D, it just really means two-dimensional. And N mode is motion over time, which I'll show you. And a lot of the machines will have some sort of pre-select. And whatever you pre-select, just be cognizant of where the indicator goes. So the first thing you need to understand once you start scanning is, okay, how deep am I scanning? You want to think to yourself, what settings should I set this at so I can obtain the image I want to look at? So you're going to adjust your depth, and you'll see little markers on the side of the screen. So depending on how deep the setting, this would be a centimeter, this is 2 centimeters, 3 centimeters, 4 centimeters. And in this case, this would be half a centimeter. And your goal here is simply to, you kind of want the image you're looking at near the middle of the screen. If you're putting in a line, this is way too deep. You need to adjust your depth. So you're probably, I don't know, 2.5 centimeters or so, and definitely not 6. Again, here's your depth markers here, and you can adjust the depth. All the machines are a little different, but you'll have a depth button, and you either scroll to the right or to the left to increase or decrease. So gain. What is gain? Gain is the amplification of ultrasound signals your transducer receives. Each echo gets turned into a lighter or darker pixel on your machine, and gain dictates how much that is amplified. So here, the move to make is to turn the gain up. You don't see much, so you want to amplify the signal here. This looks about right. And here, this is way too bright. So what I would do here is reduce the gain, turn it to the left, or slide the lever down. Within the gain setting, most machines will have an all, near, far, or auto gain. When you select all, the entire screen, the gain will be adjusted. If you just select near and then adjust the gain, just the top part of the screen will be adjusted. If you select far, just the bottom part of the screen or further the image will be adjusted. So you can adjust all, near, far, and then also most machines will have some sort of auto gain that will put it at a close setting for you. Another set of buttons to be aware of are most will have a general penetration and resolution setting, often labeled Gen Pen Res. Now remember, these probes have a range of frequencies, and remember, the lower the range, the more penetration. So if you put this on a penetration setting, it'll take that probe to the lower frequency and you'll have better penetration. Conversely, you want to take that machine up to the higher frequency of its range. You put the machine on resolution, you'll go a higher frequency, you'll have better resolution. I would say most practitioners use the general mode, but now you will have an idea of what that setting does. M mode. So M mode just means motion over time. So this is a setting where you can look at one area. In this image here, we are looking at this line here over time. So this is your timeline running this way. Again, this is that line, so this would coincide with this. This little black area here would coincide with this. We'll talk about this in other lectures, but this is a good way to document your findings. So even though we see, like, let's say, variation of some sort, to document that, you would use motion over time. So here you see what's IVC variation over time. Another good use for this is lung sliding, so you can document movement over time with the ultrasound machine. And then other. So most brands of ultrasound machines are going to have some sort of proprietary algorithms and software that enhance the image you're looking at. And depending on the brand, what this is called might be different. So this particular brand has what's called MB mode, or multi-beam imaging mode. And then you may have a brightness control, which is different than the gain, but less important, and then a zoom function. Again, these are things most clinicians don't use as far as critical care, but things to be aware of. And then finally, this setting again is less frequently adjusted in our setting, but time gain compensation. So TGC is a setting in ultrasound that compensates for the loss of signal strength as the ultrasound beam penetrates deeper into the tissue. As sound travels far through tissue, it loses energy due to the absorption and scattering, causing the reflected signals from deeper structures to be weaker than from superficial structures. So really, the time to know about this setting is when you are messing with your machine and it's all black. Somebody may have adjusted these. But for the advanced ultrasonographer, this allows more fine-tuning of deeper structures and more tweaking of the image you obtain on the screen. So take-home points. Fluid is anechoic, it's black. Things like bone, diaphragm, pericardium, those are hyperechoic, they're white on the screen. Tissues, muscles, those are going to be some sort of shade of gray. Always know where your indicator. The indicator on the transducer corresponds to the orientation mark on the image. Use the higher frequency linear probe for vessels, potentially the lung, and the lower frequency phased array probe for the chest and abdomen. You can also use the convex probe for the abdomen. Probably the most common mistake I see is the depth is off for new learners. So always think about the depth when you scan. Think where your structures are and adjust the depth. And then also you want to adjust the gain for each exam. And then remember, this presentation covers the basics. It will get you started, but there is much to learn about ultrasound. It's an entire science. However, I feel this is enough to get you started. All right, we're going to finish with some questions. So what color does fluid appear on an ultrasound image? White, gray, black, red. How do bone, diaphragm, and pericardium appear on an ultrasound image? Anechoic, hyperechoic, shades of gray, none of the above. The answer would be hyperechoic or white. The indicator on the transducer corresponds to what on the image? A, the depth of the image, B, the gain of the image, the orientation mark on the image, the frequency of the probe. The orientation mark on the image. Which probe is best suited for imaging vessels? High frequency linear, low frequency phased array, medium frequency convex, none of the above. High frequency linear. Which probe is best suited for imaging the chest and abdomen? High frequency linear array, low frequency phased array, medium frequency convex, none of the above. Actually, if you can only choose one, you want to choose the phased array. Remember, the phased array will get between the ribs on the heart, so the chest. However, the convex could be used to scan the abdomen, but when you go to image the heart, it will obtain the subxiphoid views, but the other images would be challenging. What should be adjusted for each ultrasound exam? A, depth and gain, and that's the answer. Always, always, always think of your depth. The most common mistake I see when people aren't getting the image they want is their depth is not set correctly. What is the purpose of time gain compensation in an ultrasound machine? A, to reduce the brightness of the image at all depths. B, to amplify the signals received from greater depths. C, to decrease the signal strength of the ultrasound beam as the ultrasound beam penetrates deeper into the tissue, or D, none of the above. And remember, time gain compensation, you generally will not adjust this in critical care ultrasound. If the machine's ever black, think of that as the cause. Other than that, I would not worry about it until much later in your learning. What is the difference between linear, phased, and curvilinear ultrasound probes? A, they produce images on different resolutions. B, they are used for different types of examinations. C, they emit ultrasound waves at different frequencies. Or D, all of the above. And the answer is D.